What happens when a misdiagnosis leads doctors down the wrong path? In a shocking twist, the real source of this patient's chronic health issues wasn't SIBO or adrenal fatigue. An MRI revealed a cascade of conditions stemming from chronic pancreatitis, a senescent pancreas, and much more. Let's break down the findings and connect the dots. To graduate from medical school or earn their certifications, doctors spend years studying the intricacies of the human body. They master organ systems, learn how they interact, and understand the physiology. Why is it, as soon as they graduate, they seemingly forget everything behind complex conditions, all the while never considering or diagnosing chronic pancreatitis, gastroptosis, or portal vein dysfunction, all of which they've had to learn about these issues to even qualify as doctors. But here's the shocking part. Despite their foundational knowledge, multiple practitioners failed to connect the dots for this patient. The MRI findings revealed clear signs like a senescent pancreas, gastroptosis, enteroptosis, and portal vein dilation. Yet none of these critical conditions were identified until they saw me at Higher Self Functional Medicine. The radiologist's report showed a senescent pancreas caused by chronic pancreatitis, a condition often overlooked but incredibly impactful. This pancreas was prone to developing pseudocysts, which are fluid-filled sacs that leak digestive enzymes and fluid into the abdominal cavity, leading to widespread inflammation. Her subcutaneous tissues, or fatty tissue below the skin, were inflamed by the pancreatic panniculitis, which is a hallmark of advanced pancreatic dysfunction. Her gallbladder had also been removed, which is a procedure performed all too frequently to treat symptoms of chronic pancreatitis, but this often misses the underlying issues. The MRI revealed a vertical stomach, also known as gastroptosis, where her stomach had abnormally shifted downwards towards her pelvis. This condition was completely missed by all of the functional medicine practitioners. It probably had started 2 decades prior during a C-section where her intestines were placed upon her chest to remove the baby. Compounding this was an engorgement and vasodilation of the portal vein. This forces blood to bypass the liver and causes venous engorgement in her esophagus. This venous engorgement in her esophagus distorts her lower esophageal sphincter, leading to symptoms of acid reflux. This malfunction disrupts her digestive chemistry and triggers severe food sensitivities as undigested food particles enter her systemic circulation every time she eats, which provoke an immune reaction, which is blamed upon the food and not upon her abnormal anatomy and physiology. The portal vein congestion didn't stop there. This vasodilation of the portal vein also caused internal and external hemorrhoids, which caused bleeding during bowel movements, and pelvic congestion syndrome, which caused problems with her menstrual cycles. Her intestines were also affected. Enteroptosis, which is the abnormal dropping of her intestines, was clearly visible and could be traced back to her C-section, where her intestines were temporarily placed upon her chest. There is good news, though. Another patient with very similar symptoms and severe reactions told of her C-section where the doctors used trays on a stand to hold her intestines, if you can call that an improvement. However, I do find it curious that both women lived in Chicago. In a healthy person, the stretch caused by food passing through the intestines stimulates coordinated contractions for the food to move down the digestive tract. However, in her condition, the displacement of her intestines created several hairpin turns that the food had to navigate through. Adding to the chaos, numerous gas pockets were seen from her stomach to her large intestine, with a significant one near the ileocecal valve. With the contents of the intestines being mostly liquid until reaching the sigmoid part of the colon, and gas being gas, it will always rise to the top of the liquid, changing locations in her intestines as she changed positions of her body. Now you should know that for a gas pocket to be seen on diagnostic imaging, X-ray, MRI, CT scan, the gas must reach atmospheric pressure, which is 14.7 psi. That is half the pressure in your car tire. A yoga stability ball is less than 1 psi. Contemplate that and how stable those balls are. Gas pressure between 0.6 and 3 psi is enough to blow open the ileocecal valve, allowing harmful backwash from the large intestine into the small intestine. However, these gas pockets stretched her intestines, triggering uncoordinated contractions and worsening her symptoms as she moved about during the course of her day. Every licensed doctor, whether at a clinic or practicing functional medicine, must pass rigorous exams in anatomy and physiology, as well as analyzing diagnostic imaging. So how could they miss such critical findings in this patient's case? This case highlights how a cascade of interconnected issues can be missed by relying on a previous misdiagnosis and not confirming the diagnosis independently. Diagnosis and treatment of her condition was delayed by using the most popular diagnosis du jour, SIBO and adrenal fatigue. From her senescent pancreas to portal vein dysfunction and interptosis, her condition tells a powerful story about the complexity of the human body. This raises an important question. Is it the system that's flawed, or are practitioners overlooking essential details? Let us know your thoughts in the comments, and don't forget to subscribe for more medical insights.